Thank you, Sunny. I think that was absolutely spectacular, and the future really looks bright for keratoprosthesis. And I'm sure both the models that you talked about are really going to be the future. So I think with this we move to the next talk, and I think is that Dr. Rohit Shetty's screen?
Yes, ma'am. I'm just trying to open my screen.
I think was it Dr. Prajana? I thought in the next talk. Anyway, now since you've opened yours, so Dr.
I
Rohit
thought on
Shetty,
my
no, it's
on.
okay. Okay, 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 fine. Dr. Rohit Shetty again is very well known to all of us. He's the clinical and translational scientist at Narayan Nethralaya, Bangalore. He's the he's going to be talking about targeting biomarkers in the dry eye, and he's done a huge amount of work at Narayan Nethralaya, Bangalore. He's a vice chairman of Narayan Nethralaya, Bangalore, and also the faculty in Department of Ophthalmology, Maastricht University. So over to you, Dr. Rohit.
Thank you, ma'am. Can you hear me?
Yeah.
Okay. Thank you, Namrata ma'am, AIOS, for this wonderful opportunity. My talk today is targeting biomarkers in dry eye. These are my financial interests. Do research with these companies. This paper just came out a few days back. It speaks about the clinical pattern of management of dry eye. It's a TFOS-based study, and we all are aware of these definitions. But what they did was we looked at different pattern of how you diagnose and treat dry eye, and what are the different modalities of treatment which has been used. And this chart is quite exciting about, looks at different places across the world and what are the major treatment options for it. You can see that there's a wide variations of it. Sometimes, some places you have anti-inflammatory immunomodulators in a smaller percentage. Fatty acids, essential fatty acid like omega-3 fatty acids have been used in many places. There's a huge amount of, and they have also used a stepwise algorithm, not much different from what we already know, but it's there in the paper. But what is very interesting is the last line of this paper, the last paragraph of this paper. It talks about this. That means we are virtually treating these diseases without understanding what is really causing this change. The biggest challenge has always been what and how do we identify these biomarkers? They're floating around all over the place, but how do you identify them? In the last 12 to 13 years, this has been my area of work. And finally, in the last 6 months, we have got this to reach the clinical outpatient of a clinician. Earlier, it used to be in the all advanced research lab. This is a point of care diagnostic kit. I call it the lab on chip. It uses ELISA fluorescence-based microfluidic device. We have these molecules which has been included based on the work done by us and all the work done by prominent scientists and researchers on dry eye, the culprits, which are the real cause of ocular surface problems. So we thought, why not build a lab on chip? And this lab on chip uses clear fluidics. And we used all these wells are where, you use the clear film proteins and, it coats with your specific antibodies and how you read it. And this is what we do in the clinics, which used to take pure research labs. It takes by the Shermer strip taken by a fellow. They extract the buffer using some the fluids there, and you shake it and extract the tear proteins and use it on the cartridges here. And this cartridge is put in a reading thing. This is used in cancer biology also. At the end of it, you get this report. Now, the best part is that you have a report which explains all the biomarkers which you have. And this is the world's first biomarkers in the tears to come out in the clinics. And this takes an hour. You look at, in the past, we have known about MMP9s, but you have a lot of other molecules, including TNF alpha, 10, VEGF. That means that it can be used for retinal evaluation. Also, you can even use the aqueous or the tears. So we did close to a few thousand eyes before we started using in the clinic to look at what are these molecules which are higher. What is interesting is we looked at controls, subclinical inflammation and inflammation. This is controls who are healthy. What is interesting is this group of people who are subclinical inflammation. That means you don't really have signs of T-Bud or Schirmer's changes in them, but these are the ones who actually trigger off a change. And this is where you have to actually treat. And this could also be a trigger if you're planning for a surgery or any of this kind. And we used all the same different molecules, whatever we have studied. And we found that the subclinical guys are the ones who are always on a different scale because they don't have the symptoms yet, but you'll start showing it up, or they may have the symptoms, but they may not have the signs. So the dry eye can present as multiple things. You can have a mix of signs and symptoms together. You may have only signs, only symptoms, but our treatment is all the same. You choose corticosteroids or you choose one of your modalities, what has been given by the paper, which I just mentioned. But what we thought was using this biomarkers. We thought the concept of biomarker enable specific targeted therapy. And this is just not for ocular surface alone. You can we have tried for glaucoma, retina, VEGF, and multiple things. And this has been area of my interest now, research of unknown. And this is where I start working on. For example, if this is a report of a patient X, and if you have an MMP9, this is what you could look at, immunomodulators. If you have an ICAM1, this is the first time an ICAM1 has been picked up. We talk about liftigras and multiple things, but we don't know how many patients have an ICAM1 increase. If you have a mix of MMP9 and ICAM1, you can combine treatments. Or if you have a multiple things in a higher level, then you can look at corticosteroids or combination of these therapies. So basically, you're trying to titrate your therapies based on what you're seeing. And this is exactly what I said. MMP9, we even quantify it. How much is the MMP9? For example, some patients have 3 lakhs. Then if you have a 3 lakhs MMP9s, which is so high, you cannot consider them to be treated just with your lubricant and cyclosporin. You may need an IPL or a LipiFlow therapies. Let's discuss a few cases. This is a 26-year-old gentleman, comes for a refractive surgery. I'll be a little quick here. And you have these changes out here. And you do the test and you see the epithelial mapping is irregular. Now the question is, why is it irregular? And then you do the test and you know that the MMP9 instead of 49,000 is close to 1 lakh. So what do? When you have such high level of MMPs, if you do a surgery on it, this patient will end up not very happy. And what happens is he will have a poor nerve regeneration. His epithelial will become messy like this, high OSDI, glare and halos, and poor quality of life. So what is the ideal approach? What we follow, you can look at doing a LipiFlow or pre-treat them with dry eye treatment. And then you probably plan it. In this case, I did a LipiFlow on him to reduce it and see this is what he had. And it just came back to 3,000. And this is when you get a proper healing. This is when you don't end up patients coming back to you being unhappy. This is a second patient, again, with no evidence of clinical dry eye, but a high level of OSDI, but his dry eye status is normal. But again, look at this. He has an ICAM1, which is very high, and also raised MMP9. See, in places where you have options of giving liftigras, this would be a great case to consider liftigras as his treatment post-surgery, because this is where you would probably being able to directly treat him because you're exactly targeting the therapy out there. And this is because that's the molecule which is affecting it. And this is very important to understand that you've been using drugs which are extremely be very careful about where do you use them, because we can't just make patients spend a lot of hundreds of dollars and say that it didn't work. That's because maybe the target may be completely different.
Have we lost the audio?
Can you hear me?
Yeah, now we can. I think in between, just for a couple of seconds, it was not there.
I'm coming to the last part of my presentation. This is a patient, all the time you're worried about the PRK haze. One of the most biggest challenges haze, and whatever you do, you sometimes do get them. And we know that what are the suspects which can cause the haze, but is there any other factors? Again, when you look at the kit here, you have this TNF alpha. TNF alpha is one of the major drivers of haze, and it can also be used for glaucoma surgeries outcomes, because again, you have when you have a fibrosis or the corneal conjunctival fibrosis or changes there, TNF alpha is a very important wound healing molecule here. So when you look at the TNF alpha, and when I do it before my surgery, I know that if this is higher, the chance of haze is higher. So you can pre-treat them, or you can use mitomycin or things differently so that it reduces before you do any procedure. So the take-home point is the future. We are coming out with many drugs. Even the previous speakers did mention a lot of new drugs, even for neurotropic keratitis or these specific target which we're having. But the question is, if you don't know what you have, you're just treating in the dark. You're shooting in the dark. So accurate diagnosis is very important. Targeted therapy is the way to go. Cancer biology is completely about targeted therapy. You can monitor the progression and documentation of patient satisfaction because you know what you're treating. And the customized approach is a way to do. And biomarker pathfinder, BMP, what we call, is probably going to be one of the future direction of it. And as we move on, we are close to around 5,000 samples being analyzed now. We have been using for vitreous, aqueous, ROP. We even want to include dopamine in the future for myopic progression. So hopefully in a few years down the lane, once it gets to all the regulatory approval, it should be in your clinic for you to use it. This is the team of scientists with whom I work, and thank you.